This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello, and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the Journal of Neuro-Oncology, published in 2026, titled Comparative Analysis of Stereotactic Radiosurgery and Microsurgery for Vestibular Schwannoma, a clinical and radiological evaluation.
This is a topic that is bread and butter for us in the skull-based world, Alara, but it's also one where the correct answer often feels like a moving target. We're talking about vestibular schwannomas, those benign, slow-growing tumors arising from the Schwann cells of the 8th cranial nerve.
Exactly. And while we know they generally grow at about 1 to 2 millimeters per year, their location in the cerebellopontine angle makes them incredibly high stakes. The study we're reviewing today comes out of Cedars-Sinai and is led by Andre Boyke and colleagues. They looked at a decade's worth of data, from 2013 to 2024, to really hammer home the differences between stereotactic radiosurgery, or SRS, and microsurgical resection.
It's an interesting time frame. Over those 11 years, our institutional philosophies across the country have really shifted. The authors note that real-world treatment decisions are frequently influenced by institutional expertise, rather than uniform evidence-based criteria. So, let's dive into how they structured this.
It was a retrospective review of 87 patients. They were quite strict with the inclusion criteria, excluding anything that wasn't histopathologically confirmed schwannoma. They tracked everything: age, gender, pre- and post-treatment clinical symptoms like hearing loss and facial weakness, and then dived deep into the radiology, specifically tumor area, brainstem compression, and Coues grade.
Let's pause on the Coues grade for a second for the residents listening. The Coues classification is vital here because it's not just about size, it's about the relationship to the brainstem. Grade 1 is small and intracanalicular. Grade 4 is large with brainstem displacement. Ilara, what did the study find regarding how we choose between SRS and surgery based on these grades?
The data showed that Coues grade correlated significantly with both brainstem compression and hearing loss. Specifically, higher Coues grades, particularly Coues 4, favored surgical management. The p-value there was 0.049, right on the edge of significance, but clinically very relevant. For tumors greater than 2.5 to 3 centimeters, or those causing disabling symptoms or brainstem compression, microsurgery remained the standard of care in this cohort.
And that makes sense. Surgery allows for immediate tumor debulking and histopathological confirmation. But let's look at the radiographic outcomes, because the difference there was quite stark.
It really was. In the microsurgery group, they achieved a median 76% reduction in tumor area. Compare that to the SRS group, which saw what the authors described as relative stability or modest growth, actually a median increase of about 5% in tumor area.
Now, for a junior resident, seeing plus 5% growth after radiosurgery might sound like a failure. But in the world of SRS, that's not necessarily the case, is it?
Right. The authors emphasize that tumor shrinkage after SRS can be delayed. In many cases, stability is the goal. SRS is touted for its minimally invasive profile and high long-term control rates for small to medium lesions, generally those under 2 to 3 centimeters. The fact that the SRS group stayed relatively stable while the surgery group saw a massive 76% reduction highlights the different roles these tools play. One is a reset button, and the other is a pause button.
But here is the part of the study I found most compelling, and perhaps a bit counterintuitive for those who advocate for SRS solely to avoid morbidity. What did they find regarding cranial nerve outcomes?
This was the most striking result for me too, Dr. Aris. They found that post-treatment rates of hearing loss and facial weakness were similar between the two groups.
Let's sit with that for a moment. Usually, the sell for SRS is that you're avoiding the risks of the operating room, specifically facial nerve injury. But this study suggests that the substantial tumor reduction achieved in the microsurgery cohort was not associated with increased morbidity compared to the SRS cohort.
Exactly. Even in the Coues 4 subset, the most difficult cases, surgery achieved significant tumor reduction with what the authors called disproportionate postoperative deficits when compared to lower grades. It suggests that in experienced hands, the surgical approach, whether it's retrosigmoid, middle fossa, or translabyrinthine, is remarkably safe, even for larger lesions.
It really validates the functional preservation mindset of modern skull-based surgery. We aren't just chasing gross total resection at all costs anymore. We are debulking to relieve the brainstem while preserving the nerves. The study notes that functional outcomes, especially hearing, are largely dependent on the preoperative auditory status.
And that's a key point for patient counseling. If they come in with CUS4 and significant compression, waiting or opting for SRS might carry its own risks of radiation-induced cranial neuropathy or, though rare, malignant transformation.
Did the paper touch on the limitations of their data? 87 patients over 11 years is a solid cohort, but it is a single-center study.
It is. They acknowledge it's a retrospective review, which always carries some inherent bias in how patients are selected for one treatment versus another. However, using paired pre- and post-treatment data for each patient helps strengthen their conclusions about tumor response.
I think the takeaway for our listeners, especially those preparing for boards or looking at their own clinical practice, is the reliability of the CUS classification. The authors conclude that it's a practical and reliable framework for treatment selection. If it's a high CUS grade, don't be afraid of surgery. The morbidity isn't necessarily higher than SRS in that group, and the mass effect relief is immediate.
And for the smaller tumors, SRS remains a fantastic tool for maintaining radiographic stability with favorable clinical outcomes. It's really about matching the modality to the tumor's morphology.
Well, this has been a great dive into the 2026 Boyke et al. Paper. It's always refreshing to see data that challenges the assumption that more invasive automatically means more complications, especially when it comes to the complex anatomy of the cerebellopontine angle.
Absolutely. It provides a really strong, data-driven framework for individualized treatment planning.
Thank you, Dr. Alara, and thank you to our listeners. We hope this helps you the next time you're in the clinic counseling a patient with a vestibular schwannoma.
Join us next time on the Neurosurgery Hub podcast for more updates from the front lines of neurosurgical research.
Until then, keep learning and stay sharp. This is Dr. Aris
and Dr. Alara. Goodbye.